What's up?
Hey, checking out tour. We're good.
Yes, good.
There we go. That's what I was. And mic test, 1, 2, 1, 2. Microphone test,
Hold on. One more time.
microphone test, 1, 2. A little bit of a rain there.
Okay.
They're gonna start in just a few moments, so
Okay, one more time.
microphone test, 1, 2.
I'm not hearing
Testing.
anything.
Talk into the room, please.
Test, 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 test.
Okay, let me go see on the other end.
Yes. I wanted to thank everyone for coming in person and braving the rain. For those of you who are virtual, shame on you for not coming with an umbrella or just getting soaked for our dear Bill Cornwell. So I want to thank everyone for coming. Bill is one of our own, and we're very proud of him. So I'm going to embarrass him just a little bit. Bill has been incredibly prolific, both at work and at home. He and his wife have had 5 beautiful children, and he has published a lot of papers despite all of that. So we have been super happy to see his growth. So he started out at Ohio State in 2000 and went there for undergrad, then went to Wright State University for medical school in Dayton, Ohio. And then he went to the University of Michigan for his residency, followed by UT Southwestern, where he spent the next 5 years working both as a clinical fellow and then also in the Institute of Exercise and Environmental Medicine. And he developed great research partnerships and mentorship collaborations there, and then did his advanced heart failure fellowship at UT Southwestern. And then we were lucky to recruit him here. Since then, he has built his own lab, as we all know, and he has developed keen interest in a lot of different fields, but mostly focusing on different aspects of exercise physiology, whether that's for VADS or long COVID, like we'll hear today. He is the medical director of the Cardiac Rehabilitation Center, sports cardiology, and cardiac stress labs. And he is the recipient of multiple awards, one of which we'll hear about tonight. He has written multiple papers and chaired multiple groups for the American Heart Association and multiple other groups. So I think we know a lot about Bill. We're very proud of him, and I want him to take it away from here. Thank you, Bill.
All right, can you guys hear me? Yeah, that sounds better. Okay, good morning. Thank you for coming. Today I'm going to talk about a couple areas that are very near and dear to my heart, both clinically, from a research standpoint, and personally as well. And you may be thinking at the outset of this, what do these 3 things have in common? And I'll tell you as we march through this, as I have taken care of many long COVID patients since this pandemic began, there is an underlying theme that unites all of these populations or these areas of interest: astronauts, autonomics, and long COVID. These are my disclosures. I'll start off with a case, a patient that I took care of that we've published on. A 24-year-old female, previously healthy, developed SARS-CoV-2 with 3 weeks of flu-like symptoms, managed conservatively at home. Over the next 5 months, she developed debilitating fatigue, lightheadedness, brain fog, along with recurrent syncope and orthostasis, and she was unable to work for those several months. When I saw her, notables from her physical exam: this was a bedside 10-minute orthostatic challenge, supine rest, heart rate 67, blood pressure was normal, and she had a tachycardic response to 10 minutes of orthostatic challenge, standing upright quietly to 103 beats a minute for her heart rate, and her blood pressure was maintained. Echo showed that her ejection fraction was normal and otherwise a structurally normal heart. Referred for cardiopulmonary exercise testing. Her peak VO2 was 41.7, which was 127% predicted. VCO2 slope of 32.5, suggesting perhaps a mild ventilatory inefficiency. Heart rate augmented appropriately, as did her blood pressure, and on pulmonary function testing, her lungs were essentially normal. Some preliminary thoughts on long COVID. We've got a lot of ground to cover over the next 40 minutes, but some thoughts that I want to start off with, just to paint with broad strokes. What we call long COVID has been present for years and manifests clinically in multiple other populations and scenarios. Long COVID overwhelmingly does not result, I'll repeat that, does not result from dysautonomia. The term dysautonomia should be used sparingly and appropriately, and we're going to make a very deep dive into autonomics. Cardiac deconditioning is a major contributor to long COVID. In the absence of overt contraindications, a tailored exercise prescription should be considered when managing patients with long COVID. And I'll leave you with this. This, I'm sure, no doubt, is a very controversial statement, but nevertheless, this has been my experience treating multiple patients. Long COVID is a very treatable condition. What is long COVID? At the outset, if you're not familiar with this, this is a figure, Larry Allen and I had the privilege of serving on an expert panel that was published about a little over a year ago now. And this just reviews symptoms and the actual definition that we think of when we talk about long COVID or PASC here. A constellation of new and persistent symptoms that last for 4 or more weeks, ideally 4 to 12, depending on some other definitions that are used. Symptoms basically that you didn't have before. There are multiple symptoms that can be used to define long COVID, but what I've highlighted in red here are the cardiovascular related symptoms, not because we're all cardiologists in the room, but because of all of the symptoms that long COVID patients have. These are the ones that are almost universally present: tachycardia, palpitations, dyspnea on exertion, exercise intolerance. Long COVID, quote unquote, has been difficult to define. It does take on many shapes and sizes. So there's a couple different papers showing that over 50 to 100 different symptoms may be present following an acute infection. This is common, up to 20 to 30% of patients, depending on your source. Like I said, common symptoms that unite every patient with long COVID: fatigue, brain fog or impaired cognition, orthostatic intolerance, profound dyspnea, fatigue, the inability really to engage or continue with normal lifestyles. As I said, diagnosis 4 to 12 weeks of these types of symptoms that were not present. And these data here, I think, really underscore the importance of finding novel ways to treat this. And it also demonstrates the severity of these symptoms. Suicide, depression are very common among patients with long COVID. In one analysis, almost 15% of people screen positive for depression and 10% screen positive for PTSD. So this is not a benign condition. One of the things that I have personally been quite frustrated with as the data have emerged on long COVID is something I'll just call paralysis by analysis. This was a recent New England Journal paper that I think just came out this week. And I've highlighted just a paragraph here of this perspective. And I'll read it here. We need to define, continuously improve, and implement standards of care and best practices built on evidence obtained through a coordinated exchange of information. Third, we can leverage innovative methods for disseminating information and providing support in order to educate clinicians, patients, and so on and so forth. So this is a perspective published in the New England Journal. And as I read this, I actually had a lot of areas of confusion. Since this is a perspective, I'm going to share mine. Patients are not interested in coordinated exchange of information and information dissemination. Disparities in symptom severity mandate implementation of effective management strategies. For the past 2 years, as I've really been taking care of long COVID patients, a lot of them come to me and they are thrown into a database and we're collecting information on them, which is fine and great. But when I ask what your other providers have done for you, the answer is overwhelmingly nothing. They put me into a database, they drew some blood, they did a stress test, they got an echo and PFTs. They did nothing to help my symptoms. So by the time patients have come to see me, they are overwhelmingly frustrated, fatigued, they're depressed. Some of them have been suicidal and they've been started on antidepressants because people have not tried to treat their actual problem. They're being entered into these databases to try to disseminate information. So I say all that to say this, that we need to be moving forward with implementing training management strategies. A lot of what I'm going to talk about today comes from a paper that is in press now with Justin Edward as the first author, one of our wonderful fellows here. And this is, I'm really excited about this paper that's coming out, not just because it reflects a lot of our thoughts and our experience with management of long COVID, but it also represents what has really become an emerging group of collaborators. And I'll highlight just a couple. Eric Rudolpher, who's sitting in the room, we'll talk about some of his data in a little bit. Aditya Perari, if you're not familiar with our new relationship with Parkview Cardiology down in Pueblo, Aditya was with me a couple months ago doing a rotating sports cardiology fellowship, so to speak. Nikhil Shamapant is just one of several house officers I've had the privilege of working with over the past 6 or 7 years. And then multiple individuals from Cherry Creek, which I think this demonstrates a growing collaboration and an ability to conduct excellent clinical and research work with our partners throughout the community. And then finally, someone who's become a very close personal friend of mine, in addition to a great colleague, international representation as well. So I said in my title that we're going to talk about astronauts. So what in the world do astronauts have to do with this? Well, these very interesting observations go all the way back to the birth of our space program, where if you read this, Orthostatic intolerance was very commonly encountered among astronauts, beginning with the Gemini, Apollo, and even the Mercury 7 astronauts. Frank Borman and Jim Lovell both fainted after a 14-day excursion on Gemini 7. Wally Schirra fainted back in 1962 after an Earth orbit. And then there's some just basic reports of what they were doing back then to try to treat these guys. They started repleting them with fluid before landing. Why did they do that? Well, there were early indications that there was a reduction in total blood volume with even short bouts of exposure to microgravity. And I want you to just remember everything that I'm showing you here, because you're going to see some recurring themes as we march through the rest of this talk. Some themes are going to reemerge very commonly, and it's going to become increasingly relevant to long COVID as we go on. So this was a paper that came out back in 1996, but it was kind of a report on our experience with the first 4 decades of spaceflight. What did we see analyzing these astronauts as they were in space and coming back? Well, about 2/3 of astronauts suffer from orthostatic intolerance for at least 10 to 14 days following return to Earth. The hemodynamic response to even small muscle exercise in these guys results in augmented heart rates, and extravehicular activities when they're in space leads to excessive fatigue with inappropriate tachycardia for any given metabolic demand required to sustain that degree of exercise. We were painting with some broad strokes early on about what long COVID is, but you can start to see immediately here that there may be some similarities between our long COVID population and the early experience with astronauts. So what's going on here? Let's go into a little deeper dive with the astronauts and see if we can learn anything about the physiology here. So this was a study, 6 astronauts who completed CPET testing to characterize peak VO2 before, during, and after either a 9 or 14-day excursion to space exposed to microgravity. So if we look first at VO2, on the left, we can see that there's about a 22% reduction in VO2 following return to Earth. And just to orient you with how all of these work, so this is 1 year before the mission, 15 days before the mission. This is microgravity, so CPET performed in space. This is return to Earth on day 0, a repeat CPET on days 1 and 2, and then 6 to 9 days afterwards. So we can see that VO2 declines following return to Earth. Cardiac output also declines by about 24%. And then if we look at the determinants of cardiac output, we first are looking at heart rate, and then we're looking at stroke volume on the right. Peak heart rate during exercise was unchanged following return to Earth, but stroke volume decreased by about 23% post-flight. Obviously, recall cardiac output is heart rate times stroke volume. So following exposure to microgravity, peak VO2 and work capacity were reduced primarily due to a reduction in peak cardiac output and stroke volume. If you calculate AVO2 difference in these patients or in these astronauts, it was unchanged. So the reduction in VO2 was related primarily to the cardiac output issue. Both microgravity and bed rest, which has been used for decades now as a surrogate for exposure to microgravity when we can't do studies in space, both microgravity and bed rest lead to reductions in both plasma volume and also precipitate cardiac atrophy. So this is a very interesting study. Healthy astronauts underwent cardiac MRI at baseline, 2 and 6 weeks of horizontal bed rest, and then astronauts completed cardiac MRI prior to and following 10 days of spaceflight. So these are just basic hemodynamic data for on the left, as I've indicated here, are patients who underwent bed rest. Spaceflight on the right. I'm not going to go through this whole thing, but just to highlight a couple notables here. If we look at cardiac output, we can see that after 2 weeks of bed rest, there's a reduction in cardiac output with a concomitant reduction in stroke volume. And you also see similar trends among the astronauts who went into space for 10 days. What happens on cardiac MRI? Well, we see that there was a reduction in LV mass by 8% with bed rest. And LV and diastolic volumes, mean wall thickness, were both reduced early on within 2 weeks, and that was sustained over a several-week period of bed rest. Now, over the past several years, obviously, people are very concerned about these physiologic changes that are occurring in astronauts, and they have developed countermeasures to try to reduce or mitigate these things from happening when you're exposed to bed rest or microgravity. So this was a study about 27, almost 30 individuals who completed 5 weeks of a head-down tilt to simulate microgravity, and they were randomized in a 2-to-1 ratio to either daily rowing while they were in bed rest or bed rest that was sedentary with no exercise. So anybody that knows me knows that before the end of this talk, you're going to see pressure volume loops and you're going to see Valsalva maneuvers, and I'm not going to let you down. So what do we see when we look at the pressure volume loop? This is the diastolic limb of a pressure volume loop. And just as a reminder, if you don't think about these things very often, the y-axis is wedge pressure, the x-axis is some metric of volume. In the rowing group, we can see that if you characterize ventricular pressure volume loops at rest and following bed rest with exercise, these are completely superimposable. But what do you see with the sedentary group? We see an up and leftward shift in the pressure volume loop, which indicates that there has been a reduction in distensibility and compliance of the left ventricle, as well as a smaller left ventricle than when they started. So there are some very stark contrasts here to the response to bed rest, deconditioning. Also, if we expose them to an orthostatic challenge, orthostatic tolerance declined with bed rest, but was preserved with exercise accompanied by volume loading. So on the y-axis here, they're calling this a cumulative stress index. This is a very well standardized metric of characterizing how long somebody can tolerate an orthostatic challenge. So it's basically the degree of orthostasis multiplied by the time in minutes. What about LV structure? Well, I've just demonstrated LV mass and LV end diastolic volumes, and we can see that among the exercise patients, LV mass actually increased. However, among the sedentary individuals, there is a substantial decline in LV mass. So cardiac deconditioning can be minimized or avoided by exercise. Volume loading helps to minimize orthostatic intolerance. Now this question comes up, so is there something wrong with the autonomic nervous system in astronauts or people that are exposed to bed rest or who are deconditioned? Well, this is a very interesting study demonstrating that sympathetic tone is appropriately augmented in response to these challenges on the human body. This was another astronaut study. Astronauts underwent hemodynamic and sympathetic assessment during an orthostatic challenge prior to and following 16 days of space flight. So first, we're looking at heart rate on the left, on the y-axis. And let me just orient you here. There were two pre-flight orthostatic challenges, a head-up tilt for 10 minutes, and then on return from space, same thing was done on landing day. And you can see that there's a large increase in heart rate in response to this head-up tilt following return to Earth from space flight, demonstrated here on the right. Now let's look at stroke volume and what happened here. Again, y-axis is stroke volume, 2 pre-flight tilt tests, and then a third on landing day. And we can see that there are large reductions in stroke volume during an orthostatic challenge on return to Earth. What happens to sympathetic tone? If you're not familiar with this, this is a very interesting test. You know, I've been doing physiology work for a little over 10 years now, and this is one of the most interesting tests I think I've ever encountered, and I have no idea where this came from, but this is called microneurography. And basically what you do is you stick a needle into somebody's nerve and you measure sympathetic tone on a beat-to-beat basis. I have no idea who thought this was a good idea. I've had this done to me 20 times. It's not the most pleasant thing, but it is a great way to look at sympathetic tone. So what we're looking at here, every one of these little bursts that you see, you can think of that as characterizing the waves of sympathetic tone or the degree of sympathetic activity. So these are representative tracings from an astronaut, pre-flight on the left, landing day on the right, supine on the top, 60-degree tilt on the bottom. And just looking at this, if you don't know any other way to quantify the degree of sympathetic tone, you can clearly see that there's greater sympathetic activity following return to Earth than there was pre-flight. If we quantify these, demonstrated on the y-axis, muscle sympathetic nerve activity, we can see that there's an increase in resting sympathetic tone and in response to an orthostatic challenge following return to Earth, which underscores again that sympathetic tone is appropriately augmented. Compensatory increases in sympathetic tone to maintain arterial pressure during orthostasis indicates normal autonomic function, a compensatory response. Along those lines, increases in heart rate during orthostasis are a compensatory response and are not consistent with dysautonomia. So now we can start to talk a little bit more about autonomics and dysautonomia in the setting of long COVID, whether it is or is not present. And this is one of the things that I've seen commonly reported, that long COVID equals dysautonomia, which equals POTS. I would argue, you can see the equal signs with the slashes through those, that those are not the same entities, and the term dysautonomia should be used very sparingly and appropriately. I'd encourage anyone who's interested in this field to read a very nice editorial titled Dysautonomia, A Plea for Precision. And I'm just going to highlight a couple sentences here that were very nicely written. Many physicians and patients wrongly equate postural tachycardia syndrome, or POTS, with dysautonomia, and use both terms interchangeably. Indeed, some advocacy groups of patients with POTS have unabashedly hijacked the term dysautonomia. In reality, there is overwhelming scientific evidence proving that, rather than a disorder of the autonomic nervous system, POTS is a highly heterogeneous syndrome with multiple comorbidities and different possible pathophysiological mechanisms. I'm not going to talk a whole lot about POTS. Happy to do that in the discussion period if there's interest. But like I said, I would say that there is a very strong misnomer in the literature equating long COVID with dysautonomia and POTS, and that really should not be done. To back up that argument, I want to talk about baroreceptor physiology and autonomics for a couple minutes here. This is a paper, I think I saw Christine Saylor in the room somewhere. This is a paper we published a couple years ago looking at baroreceptor physiology and autonomics in patients with heart failure before and after LVAD implantation. But these are reference groups, healthy individuals who completed just a Valsalva maneuver. So I'm not going to walk you through the details of the Valsalva maneuver. We can do that in the discussion if there's time. But there's two main phases, so to speak, of the Valsalva that we want to focus on. One is early phase 2 and one is phase 4. And what you see here is that in phase 2 of the Valsalva maneuver, there's a reduction in blood pressure and a concomitant increase in heart rate in order to stabilize blood pressure, which you can see here is happening as a result of the increase in heart rate to maintain cardiac output. The second thing that you see, phase 4, you can see that heart rate declines as blood pressure increases during the phase 4 hypertensive overshoot. What does dysautonomia look like? This was a paper or a study that I helped with during my time back in Texas, where we administered drugs to basically induce dysautonomia. And this is what the Valsalva maneuver looks like in somebody who has dysautonomia. We have pharmacologically induced it here for reasons I won't discuss in the interest of time. But the take home here is that increases in heart rate are not necessarily indicative of dysautonomia. You see it right here in a Valsalva maneuver in a healthy individual. The inability to regulate blood pressure suggests dysautonomia. Be careful when using the term dysautonomia. As I said, dysautonomia has been implicated as the cause of orthostatic intolerance and syncope in long COVID. This was a paper that came out in JACC, and I'm going to be very critical of this. I honestly do not understand how this got published in JACC. Long COVID patients underwent a hemodynamic assessment during a 70-degree tilt, and they were given nitroglycerin if a normal response to orthostasis was demonstrated during a tilt. So if they didn't become presyncopal or syncopal, they were given nitroglycerin to try to precipitate that. 4 patients had a POTS-like response on the left. In the middle, what they call a POI, or postural orthostatic intolerance. And then on the right was postural orthostatic intolerance with overt syncope following administration of nitroglycerin. This is a little hard to tease this out, and I apologize if anybody is colorblind, but these are the colors they gave us. Blue is systolic blood pressure, orange is diastolic, green is heart rate. And what I want to point you to here is first their discussion. We believe that a postural orthostatic intolerance response seen in these subjects is significant and may suggest underlying autonomic dysfunction following COVID. Why are they saying that? Well, what we're seeing here is that in green, or first in blue, when nitroglycerin is administered, there's a reduction in blood pressure with a very large concomitant increase in heart rate in order to try to maintain cardiac output and blood pressure. So the increase in heart rate in response to a drop in blood pressure, as I've shown you, just looking at a Valsalva maneuver, and we're going to go into this in more detail in a couple minutes, this is a compensatory response and demonstrates normal baroreceptor physiology. So I've discussed this paper with several people around the country who think a lot about autonomics. This confuses a lot of people how this could be, the conclusion drawn from this could be that this is evidence of dysautonomia when you have an appropriate compensatory tachycardia in response to a reduction in blood pressure. That demonstrates normal baroreceptor physiology and not autonomic failure. A syncopal response to iatrogenic reductions in blood pressure, particularly in the presence of a compensatory increase in heart rate, is not evidence of dysautonomia. Again, what does dysautonomia look like if we just look at a Valsalva maneuver? On the top here, you can see healthy individuals. On the bottom, you can see what we see in autonomic failure or dysautonomia. The two main features that you see: absence of a late phase 2 response. If you look on the bottom here, we just see this continued reduction in blood pressure. And then number 2, we have this absent hypertensive overshoot. So again, here's your hypertensive overshoot in a healthy individual. This is the absence of a hypertensive overshoot with a very delayed return to normal of your blood pressure. So what's it look like in somebody with long COVID? This is a paper, again, from Justin Edward, who has been a wonderful fellow to work with during his Blount Fellowship for the past year. This is a 54-year-old lady who's participating in one of our studies right now. And what you can immediately see if you look at the Valsalva maneuver in her is that we have stabilization of blood pressure during phase 2B of the Valsalva, and we have very clearly demonstrated the presence of a hypertensive overshoot. Features, again, that do not suggest presence of dysautonomia. What about deep breathing? In the interest of time, I'm not going to go into a lot of the physiology of deep breathing, but it is a very helpful test when you want to look at the integrity of the autonomic nervous system and more specifically the cardiovagal component of it. So this is an example hemodynamic tracing from a patient, again, in one of our studies that we're doing, who's doing controlled breathing at 12 breaths per minute. And you can very nicely see that demonstrated in the EKG signal. We're looking at heart rate here, systolic and diastolic blood pressure. You can see very rhythmic, recurrent oscillations in these factors over just a 1 minute period. We're doing this for 6 to 8 minutes for robust data collection. But if I can just point your attention to heart rate, you very clearly see heart rate variability during the controlled deep breathing period. What does it look like if somebody has dysautonomia? This is almost a flat line. There's very little oscillations in heart rate during deep breathing. So the preservation of heart rate variability is consistent with normal cardiovagal function and reinforces the concept that autonomic function is preserved in these patient populations. So what does dysautonomia look like? Well, if you're going to have a patient who has dysautonomia, there are a couple key clinical features. Number one, postural hypotension. And I underscore the word hypotension. The blood pressure drops in response to an orthostatic challenge because of an inability to regulate or maintain a blood pressure. Urinary dysfunction, sexual dysfunction, bowel dysfunction, decreased sweating. Every one of the long COVID patients that I see, I ask them about all of these symptoms to try to discern whether or not there's any evidence of dysautonomia. And the answer to these questions is overwhelmingly no. They sweat normally and they don't have any issues with urogenital function. And as I'll show you, they actually do maintain a blood pressure in response to an orthostatic challenge. Why should we care? Who cares about this? Well, I would argue for several reasons this is pretty relevant. We need to understand the underlying mechanisms which inform treatment strategies. Number two, we need to have the correct diagnosis given to our patients. Number three, I've had a lot of patients who get confused and believe they have diagnoses they don't have and suffer from pathology that is not there. Fourthly, I've had a lot of experience with this, taking care of long COVID patients. Incorrect diagnoses lead to the ordering of tests that are not necessary, medications that are not indicated, and unhelpful consults. So we've talked a lot about astronauts. We've talked about autonomic function. There have been some telltale signs of something called cardiac deconditioning that I'm going to argue is central to the physiology of long COVID. I want to take a couple minutes just to talk about what exactly it means to have deconditioning. I've tried to explain this to patients. Several of them get frustrated. They think I'm trying to accuse them of being couch potatoes, and that's not it at all. There's a very specific physiologic construct that goes along with cardiac deconditioning. A few things. Number one, reductions in total blood volume, excessive falls in stroke volume in response to an orthostatic challenge, and there's a reduction in distensibility of the left ventricle, smaller volume for any given pressure. Some of this should sound similar to the astronaut physiology I showed you a few minutes ago. These are healthy subjects who underwent a hemodynamic assessment before and after 2 weeks of bed rest. And just to highlight a couple of these things, after 2 weeks of bed rest, there is a reduction in plasma volume. There was a reduction in orthostatic tolerance, and there was an increase in steepness of the Frank-Starling curve. And you may ask, what in the world does that have to do with anything? And what I would say is, if you think about starting here, kind of right, yeah, that's showing up. As your Frank-Starling curve drops, that is a reduction in stroke volume in response to a reduction in volume or in filling pressures. That's what occurs when you stand up. So if you have a steeper Frank-Starling curve, you have a greater reduction in stroke volume, which means you're not adequately perfusing your head, which means you get lightheaded and you have brain fog, and you're not adequately perfusing your body, which means you have a hard time exercising. I have to point out the landmark studies that were done here, the Dallas bed rest studies. If you haven't come across these really are worth a read because they were foundational in understanding cardiovascular physiology and really changed the way we treat patients in a host of scenarios. The initial paper came out back in 1968. What'd they do? Well, they took healthy 20-year-olds and they underwent exercise testing before and after 3 weeks of bed rest. You can see that there was a reduction in VO2 by about 25% following 3 weeks of bed rest, reductions in peak cardiac output following bed rest. Blood pressure during exercise was reduced despite a compensatory increase in TPR during exercise. But they did not stop there. Following 3 weeks of bed rest, participants completed 8 weeks of exercise training, and you can see that exercise led to an improvement in VO2 by about 60%, actually higher than it was at baseline. Stroke volume improved, cardiac output improved following exercise training. And the summation here is that exercise hemodynamics following training were as good as, if not better, than baseline. So to build on that, and this is where this study gets very interesting, 30 years later, these same individuals came back to complete the same exact test so that you could compare the effect of 3 weeks of bed rest when you're healthy 20 years old and how that compares to 30 years of aging. So what did they find? Well, you can see on the y-axis here, first we're looking at maximal heart rate, baseline testing, testing after bed rest, and then 30 years of aging. The increase in heart rate during exercise following deconditioning is displayed here. You can see that heart rate was higher, and there were age-related declines in peak heart rate during exercise. No surprise at all there. What about stroke volume? There were reductions in stroke volume during exercise following deconditioning. I've shown you those data. But impressively, 30 years of aging had no effect on stroke volume during exercise. If anything, it increased. What about cardiac output? Similar trends. There was a reduction in exertional cardiac output following deconditioning. Cardiac output during exercise did not decline with age. And this is where this gets really interesting. Oxygen uptake. There was a reduction in VO2 during exercise following bed rest deconditioning. But with aging, there were similar reductions observed with 3 weeks of bed rest. So what do you make of these data? Well, I'll let the authors speak for themselves here. Darren McGuire, who was here last week, actually was the first author on this paper. Most notably, 3 weeks of bed rest in these same men at 20 years of age back in 1966 had a more profound impact on physical work capacity than did 3 decades of aging. Again, underscoring the, I would say, disastrous effect that deconditioning and bed rest can have on patients. But not all patients with COVID are bedridden for 3 weeks. In fact, in my experience, I would argue the overwhelming majority are not. They're rarely hospitalized, and usually they're only down for a short period of time. But in another interesting article, I would argue that deconditioning can begin with less than 1 day of bed rest. These were healthy individuals who underwent exercise testing before and after a 20-hour period of bed rest. We're looking at a lot of factors here. Central venous pressure, you can see, was reduced by about 14%, and there was a reduction in blood volume by 8%. Heart rate, blood pressure, recall, blood pressure is cardiac output times TPR. That'll become relevant here. Cardiac output declined by 17% with 20 hours of bed rest. Stroke volume was reduced. There were large compensatory increases in TPR, again, in order to try to maintain a blood pressure. So blood pressure was normalized following 20 hours of bed rest by a large increase in TPR to compensate for reductions in cardiac output and stroke volume. What happens when these individuals are exposed to an orthostatic challenge? This is going to start to sound like long COVID here very soon. Well, there were similar reductions in CVP in response to orthostasis. There was a 30-point increase in heart rate during orthostasis following bed rest, or said another way, for any given level of orthostasis, heart rate was 30 points higher than it was at baseline. Blood pressure was similar, cardiac output was similar, stroke volume was reduced by 40 mils per beat following bed rest. Again, this is only 20 hours in healthy individuals. So what's going on here? Well, cardiac output is maintained by a large increase in heart rate in response to that reduction in stroke volume. Again, 40 mils per beat reduction in stroke volume with a compensatory increase in heart rate in order to ultimately try to maintain a blood pressure. What about symptoms? Well, at baseline, these are healthy individuals, no symptoms at all. Following bed rest, 80% had presyncope for the same degree of orthostatic stress. Again, these are young, healthy individuals that are exposed only to 20 hours of bed rest. Or said another way, 20 hours of bed rest can lead to profound orthostatic intolerance with very interesting hemodynamic changes. What about exercise? Same individuals. Well, heart rate response to exercise. Again, this is going to sound similar to long COVID. At any given level of work, heart rate was about 40 beats higher than baseline. Cardiac output was similar. Stroke volume was 20 to 40 mils per beat lower at any given level of work. Total peripheral resistance was similar due to compensatory changes that occurred. So as a result of the reduction in stroke volume, we have a compensatory increase in heart rate in order to ultimately try to maintain cardiac output. That said, peak VO2 was about 10% lower and overall exercise tolerance was reduced, again, with 20 hours of bed rest in previously healthy individuals. So what can we conclude from that? Well, a short period of bed rest leads to substantial cardiac deconditioning, which manifests clinically with orthostatic intolerance and impaired functional capacity, with hemodynamic changes occurring that are quite similar to what we've seen in long COVID patients. Now, I've said a few times here that deconditioning can lead to reductions in plasma volume, and in a recent study that came out from Donna Mancini, we actually see similar things in patients with long COVID. These were 7 individuals who completed an invasive CPET to characterize resting and exertional hemodynamics. I'm just highlighting here RAs, right atrial pressure, mean PA, and wedge pressures, and you can just see these are all really low, 0, 2, 4, wedge pressures of 1, 5, and 4. Those are pretty low. What effect does that have, or what's the clinical relevance? Well, those individuals had blunted stroke volume reserve revealed during exercise with an average stroke volume increase of only 18 mils per beat. That's pretty low. For anybody that does invasive exercise testing, you'll know that stroke volume reserve should be much greater than that, sometimes up to 50% of your resting stroke volume. So reduced filling pressures impair stroke volume and cardiac output reserve during exercise, contributing to impairments in functional capacity. What about their overall functional capacity, can we say? Again, Justin Edward and I wrote this not opinion piece, but more of a scientific review for the ACC that was published not too long ago. But just to highlight a couple things here, peak oxygen uptake among patients with long COVID is either normal or mildly reduced, as low as 80, maybe 75% predicted. Ventilatory efficiency is normal or mildly impaired. Breathing reserve is normal. Maximal heart rate is normal or perhaps mildly depressed. There have been some studies reporting mild chronotropic incompetence. Lung function testing shows normal FEV1 and, for the most part, normal lung function. This was a review by Naiji, who commented on similar data that Justin and I did. And what did he conclude from this? Well, he said altogether, the CPET data profile is consistent with deconditioning during recovery of an acute inflammatory process, bed rest, and PTSD and depression. We don't really see evidence of overt organic abnormalities in the cardiopulmonary system. It's more a result of deconditioning. So what do we do with all of that? Well, we've talked now about how astronauts have deconditioning, how exercise, volume loading may mitigate entirely the effect of deconditioning on the human body. And for those reasons, we have advocated a couple times now that exercise training, in the absence of any overt contraindications, should be included in your management strategy. This is, again, from the expert consensus decision pathway that Larry and I had the opportunity to serve on. And this is a publication. You can see first author Eric Rudolpher sitting here in the audience. Now, that said, there was a recent, this has been around in the literature, but in a big way, it showed up in Nature not too long ago, where patient advocacy groups are asking the NIH to stop funding studies looking at the effect of exercise on long COVID due to concerns that you can significantly exacerbate post-exertional malaise. What's this all about? Well, many groups have equated long COVID with POTS, with dysautonomia, with something called MECFS, myalgic encephalomyelitis / chronic fatigue syndrome, which you can see how that is defined here. My commentary on this, number one, the criteria for MECFS are very broad, generic, and absolutely do not point to any specific pathophysiology to guide treatment. Number two, I do agree with the authors on this, that an overly aggressive exercise program could actually exacerbate post-exertional malaise. That said, an exercise prescription appropriately tailored to the deconditioned patient, in my experience, and we have data to support this now, will not exacerbate post-exertional malaise, and exercise for that reason should not be avoided when it may actually be the best thing that they have to try to alleviate their symptoms. So how are we exercising patients here? I developed this protocol very early in the COVID pandemic, really before long COVID became a thing. Clinically, I was getting referrals for patients with unexplained dyspnea, fatigue, orthostatic intolerance, and on questioning them, it became pretty apparent early on what the pathophysiology was here that was driving their symptoms, and that's why this protocol is designed the way that it is. If you look on the y-axis here, this is a 12-week-long protocol, and on the x-axis here, this is how many minutes per day we ask our individuals to exercise. Early on, it's 5 minutes a day. We ask them to exercise 5 times a week for 12 weeks. I tell them it's a commercial break. Anybody can do that, especially when it is at a very low intensity. So again, we're trying to design an exercise intervention strategy that allows deconditioned individuals to exercise without exacerbating post-exertional malaise. And one of the, what I would say perhaps is a valid argument by people who are not in support of this, if you implement an overly aggressive exercise strategy, you are going to exacerbate post-exertional malaise and people are going to quit exercising. If you do it the right way, you actually can guide them through that very effectively. So we're starting off exercising 5 times a week, 5 minutes a day, but every week you increase by 2 minutes a day. So that by the time you get to weeks 10, 11, and 12, you're now exercising by rowing 25 to 27 minutes a day. I don't know if anybody's ever rowed before. I row a lot. If you can row 25 minutes a day, you don't have long COVID anymore. There's no other way to say it. There are reasons why we choose recumbent and semi-recumbent types of exercise, and we'll talk about that here. Rowers, long story short, have some of the biggest hearts of any athlete. So these are old data, a little over 30 years now. These are almost 1,000 elite athletes who underwent imaging assessment of ventricular dimensions just with echo. And you can see the spread here on the y-axis, number of athletes, on the x-axis, how thick are their walls. And you can see that about 16 had wall thicknesses that actually were in the range of patients with hypertrophic cardiomyopathy. If you look closer and you take a history on this, the overwhelming majority of these individuals were rowers. So for this reason, it's been said for almost 30 years now that rowers have some of the biggest hearts of any athlete. Why is that? Well, if you look at structural adaptations to exercise, it is not uniform. And when I see a lot of athletes, I provide a lot of counseling on different types of exercise. And my number one question is always, what are your goals? What is it you're trying to achieve with the type of exercise that you're engaging in? Because your body's going to respond a different way to different types of exercise. So if we think about endurance exercise, running, those types of things, we see 4-chamber enlargement, eccentric hypertrophy, right ventricular dilatation. If you look going to the right, however, strength training, we see concentric hypertrophy, unchanged right ventricle, reduced left ventricular relaxation in extreme cases. But the point that I want to underscore here is that not all exercise is built the same, and we're going to see different types of remodeling of the heart in response to different types of exercise. This is how the ACC generally stratifies different types of exercise according to a static component. You can think of that as being maximal voluntary contraction. If you think about squeezing something the hardest you possibly could, versus dynamic component, running. So where do different types of exercise fall on this? You can think about low static, low dynamic, golf. Running, highly dynamic, low static. Weightlifting, rock climbing, highly static, high dynamic. Why is rowing special? Because it's both. It's both highly static and highly dynamic. So the last slide I just showed you, the structural responses that we see in the heart based on different types of exercise. And this is why rowing is great. 3 reasons. Rowers have the largest hearts compared to any other athlete. Number 2, while we're talking about trying to improve functional capacity in long COVID patients who can't even walk for more than 2 or 3 minutes, it recruits a large amount of muscle mass, basically every muscle from your neck down. And then number 3, it allows you to get some real work done with the gravitational load minimized or entirely absent. You're not standing upright, you're exercising with your body like this. So we have greater stroke volume available, greater blood volume available for your heart to augment stroke volume during exercise. A couple other things, just as we're starting to close up here. What are the other subtle but very relevant and important physiologic responses to exercise? This was a study I helped from several years ago in my previous lab in Texas. Again, we're looking at pressure volume loops, the diastolic limb of a pressure volume loop. And what was done here was healthy seniors who are about 70 years of age, who exercised to varying degrees throughout their adult life, were stratified according to how much exercise they did. You can see how this was defined. Sedentary, less than 2 sessions per week. Casual, 2 to 3 times per week. Committed, 4 to 5. Competitive, 6 to 7. What do you see here? Well, for individuals who exercised 4 to 5 times per week throughout their adult life, we see that there is a down and rightward shift in the diastolic limb of your pressure volume loop. But if you were sedentary during your adult life, when you got to your elderly years, you had this up and leftward shift in your pressure volume curve, indicating that you have a stiff, smaller left ventricle. This underscores why everybody in this room should be exercising throughout their adult life, and it also underscores why exercise intervention strategies can help preserve a youthful appearing heart as we age. Building on that even more, this was another study we did back when I was back in Texas. Previously healthy individuals who were about 55, well into middle age, completed hemodynamic assessments prior to and following a 2-year bout of exercise training. So again, the diastolic limb of a pressure volume loop, you can see in black individuals who were controls, who did just yoga for 2 years versus an exercise group. And you can see that after 2 years of exercise, we have, again, a down and rightward shift in your pressure volume curve. How did we exercise these guys? A combination of HIIT training, moderate continuous exercise, and some exercise training or some strength training built in there. So these are very interesting data. Number one, the left ventricle retains a high degree of plasticity well into midlife. We can exploit that by having people exercise. Exercise takes advantage of this, improving compliance and restoring a youthful appearing heart. You know, it's interesting. If you look at those data I showed you the last slide, where does the pressure volume curve fit? If you stratify young, healthy individuals on a 70-year-old pressure volume curve, if you exercised 4 to 5 or 6 to 7 times throughout your adult life, your heart actually looks like a 20 or 30-year-old when you're 70 years old. It's remarkable the impact that exercise has on your heart. So what are we doing here? This is a study, again, back to Justin Edward. I'm going to continue to highlight him because he's been a wonderful fellow to work with this past year and a half. We are testing long COVID patients in the following way now. We have them come in for baseline assessment. They then are randomized to either exercise training, preferably with rowing or cycling, versus usual care. They come back for a follow-up visit. And then if they exercise, they're done. If they were a control, then they cross over to complete 12 weeks of exercise and they come back for a follow-up evaluation. I'm just going to show you, in the interest of time here, some of the data that we see in response to an orthostatic challenge. Remember, I told you, if patients have dysautonomia, there's an inability to regulate or control blood pressure in response to orthostasis, and that is not what you see here. We first see a large increase in heart rate that's consistent with deconditioning, and then we see, oh, sorry, this should say systolic blood pressure. We can see that systolic, diastolic, and mean arterial pressures are all preserved in response to a 10-minute orthostatic challenge, which again underscores that there's a compensatory increase in heart rate to try to maintain cardiac output so that blood pressure is preserved, and this does not indicate dysautonomia. So back to the case that I shared in the beginning, this 24-year-old on follow-up, she was initiated on this protocol over a 12-week period. At 8 weeks, she completed a 7-day backpacking trip in the Sangre de Cristo Mountains, and at 12 weeks, she climbed the summit of Mount Democrat, and she was able to return to work full-time with resolution of her symptoms. All of this work has actually led to the attention of the American Heart Association. I have the opportunity right now to chair a statement that'll be coming out either later this year or next year, talking about a lot of these issues and some exercise strategies we can use to consider treating patients with long COVID. And I'm also going to highlight Justin again. It's not very often that a cardiology fellow finds his way onto an AHA scientific statement, and he is able to serve on that with me. So I'm very excited about that. In summary, in closing, long COVID is common following SARS infections, and among other symptoms is characterized profound fatigue, orthostatic intolerance, and brain fog. Though the term quote unquote long COVID is relatively new to us, very similar conditions have been reported for decades in a host of patient populations and scenarios. True dysautonomia rarely occurs and should not be implicated based only on the observation of a compensatory tachycardia in response to orthostatic challenges or exercise, which is an indication of normal autonomic function. Cardiac deconditioning, characterized by reduced plasma volume and ventricular distensibility, combined with steepening of the Frank-Starling curve, is a central component to long COVID and other similar conditions. For those reasons, I would say that an exercise regimen tailored specifically to this unique physiologic characteristics of this patient population should be incorporated into patient management. In closing, I just want to thank a lot of collaborators. I think Jeff Hebert is sitting in the room. Notably, he and I just received an AB Nexus Award to do some very interesting work on autonomics with aerospace engineers up in CU Boulder. Other collaborators, both here locally and also throughout the nation and internationally. For any fellows that are interested in doing some, what's really become very interesting and exciting areas of research. One of our fellows I was able to send over to the Aegean Sea last summer, spent 3 weeks scuba diving. and is now working on manuscripts. So a lot of fun work going on. With that, I will stop, and in the remaining time, take any questions. And thanks for your attention.
I wanted to thank everyone for coming, and we have questions, but I also wanted to thank Amanda Cornwell, who's standing at the back. Amanda, can you stand up? Bill couldn't do any of his work if it wasn't for you. So we need to recognize you.
Thanks, Bill. I'll second Bertiti's comment that it's nice to see all the work that you've done. I also want to highlight how important it is to see the integration that you've done between the fellows, our satellite sites, and the work that's happening here on campus. There's been a lot of discussion about integration of clinical mission with research, and you set a great example for that. So thank you. One question I have for you, I'm actually very impressed by your lecture and how much data you put into it. But one of the things that strikes me is that most long COVID gets better. And I don't think you showed any randomized data of people randomized who have long COVID, who get randomized to exercise versus not, and whether it's the exercise or just time that is improving the
Absolutely,
outcomes.
and that's a great question. I personally disagree that the majority of long COVID gets better. I've seen this week, I saw 2 patients with long COVID who developed COVID in January 2020 at the outset of this pandemic. I'd imagine some of it gets better. I'm not sure that it universally gets better, but that's why in this study that we're doing now, we have controls with no intervention for 3 months to test that hypothesis. We have not been doing this study long enough to actually report on that formally. Anecdotally, having treated, I don't know, 100 or 200 patients, it's been my experience overwhelmingly that many long COVID patients have had symptoms for 1.5 years or 2 before they get to me. Maybe it gets better in some cases. I absolutely disagree with the notion that it universally improves. Data will tell. That's been my anecdotal experience treating a couple hundred patients now.
Thanks, Bill. Over here, Eric. I think you make a really good argument for the separation of dysautonomia and long COVID. Some of the data that you showed, especially in heart rate response with maintenance of blood pressure, we do see those sorts of changes in patients with POTS as well.
Yeah.
Can you maybe clarify some of the key distinctions between long COVID and POTS?
Yeah. POTS. Okay. POTS is not long COVID. They have, the way I describe this to patients is they have shared features. They're not the same. Just like reflux and a heart attack can cause chest pain. Chest pain is the shared feature between 2 clinically different syndromes or phenomena. A POTS-like response is evident in patients with long COVID. That does not mean they have long COVID. POTS, let me get the, yeah, here we go. Multiple hits result in POTS. There's clearly a genetic susceptibility. Usually people were highly active. There's an inciting event that leads to a downward spiral where you have worsening symptoms that leads to a reduction in activity, which leads to deconditioning, and around we go. Similar features are present with POTS or with long COVID. That does not mean, nothing in here says that these individuals have dysautonomia. There's a classic paper, Jack 2010, where POTS was named the Grinch syndrome. You've probably seen this in the literature. It showed up on Jeopardy about 1 year ago and just caused a firestorm. But the reason I like that term is because you'll never forget the physiology of POTS when you read that article or just think about the Grinch syndrome. It was called the Grinch syndrome because the heart of patients with POTS is small, which means stroke volume is low, which means there has to be a compensatory increase in heart rate in order to maintain a cardiac output in response to an orthostatic challenge. And that's the physiology of POTS. There's nothing in there that speaks to dysautonomia, though a minority of patients with POTS can have a very heterogeneous syndrome with evidence of dysautonomia, but that is not the overwhelming physiology. Overwhelmingly, it is a cardiac issue with a small heart, a small stroke volume, a compensatory increase in heart rate to maintain a cardiac output that results from a very heterogeneous series of events. What is your theory on why we are seeing so much of this COVID? And not with H1N1, other influenza, RSV, and Canada, I think it's because of the media, because we live in 2023. There's TikTok, Facebook, MySpace, and all the other things where people are reporting on this 24 hours a day. And if you just go back in time and read the reports of post-viral syndromes in a number of scenarios, it's all very similar to this. We live in a different day and age now where the media allows this broad access to speak. And that's why, like I said, long COVID is relatively new to the medical lexicon, but the syndrome has been present for years. And you can just go back into the data 50 or 60 years ago and see that. I think all of the above. Yeah.
Are there,
Yeah, oh, gee,
there's
yeah.
another question. I have to add that I'm proud to be the first volunteer in Bill's lab. When he first moved here, he never told me my VO2. And it's
That's
probably
true.
because I do
We-
yoga, which is not real
We had some
exercise.
dry runs on volunteers to get our equipment up and running.
So Bill, a lot of this sounds like it's just the bed rest and the response to an illness. So does it have anything directly to do with infectious diseases, or can you see this in other types of diseases?
There are some data to suggest that the inflammatory response to an infection may contribute to these kinds of abnormalities. Absolutely. And that's also why you see this same clinical manifestation show up in a host of other conditions. Absolutely.
Okay, I can really yell. Bill, that was wonderful talk. Oh, okay, good, thank you. And I look forward to our future collaborations.
Absolutely.
One granular question. I really loved how you put out the criteria for dysautonomia. Where do you think, or do you fit in their response to exertion exercise in heart rate response? Is
If-
there a blunted or
If
nothing?
you lack the ability to maintain a blood pressure during exercise, that would be suggestive of some evidence of dysautonomia. If you have an abnormal exercise pressor reflex in the inability to regulate a blood pressure. I had this show up in a kind of a funny, it's funny because it ended well. We had a patient who was walking and got onto an elevator. He had autonomic failure, and this will illustrate the point. He was walking, got onto an elevator. The elevator went to the 4th floor, and he never showed up to clinic. And we went to go look for him, and he had passed out walking off an elevator. Half of his body was in the elevator and half of it was not. So the doors were just closing, opening, closing, opening. And it underscores the inability to regulate a blood pressure during exercise. Hypotension, passed out, syncope. Data I didn't show in the interest of time, but has been demonstrated in our cohorts and also others that have been published. Blood pressure is augmented during exercise in patients with long COVID. In my mind, that in no way, shape, or form is suggestive of autonomic dysfunction.
Mhm. What about heart rate?
The heart rate response, if you lack the ability to appropriately augment a heart rate in response to a metabolic demand or metabolic challenge, that would be suggestive of dysautonomia. But when it increases appropriately, that certainly doesn't sound like dysautonomia to me. Was there a hand? Go ahead.
Thank you, everyone, for coming. You can come
Thanks.
up and talk to Bill in front if you want.
All right.